Good afternoon, dear colleagues, dear guests, dear friends. We are about to begin our MED talk that is dedicated to cognitive impairments, diagnosis, treatment, and prevention. It was organized by the Solovyov Scientific and Practical Psychoneurological Center. We are proud of the fact that apart from borderline impairments, we also deal with cognitive impairments, vascular impairments. All of that has become possible thanks to the fact that over the last few years, neurology and psychiatry have become quite close. At the beginning of the 20th century, they got separated, but now the contemporary trend is towards convergence. We are going to try to show you all the facets of brain diseases. During the Health Assembly, we are having 3 events. Tomorrow there will be 2 more of our events. We try to show that psychiatry and neurology go hand in hand. They go together in collaboration. I would like to introduce our speakers. Today we have a guest from France, Professor Didier Leys. He has been head of neurological clinic in Lille, president of the French Neurological Society and Neurological Academy. Now he is editor-in-chief of the European Stroke Journal. Our second speaker is Ala Gacht, Doctor of Medical Sciences, Director of the State Budgetary Institution of the Health, Scientific and Practical Psychoneurological Center named after Solovyov, member of the World Neurologist Federation. So, cognitive impairments. First of all, we are going to give the floor to our guest, Didier Leys.
Thank you very much. I would like to start by thanking Ala Gacht for this new invitation in Moscow. I would like to thank also the Russian authorities in Paris at the embassy because I had some problems with the French post and I succeeded to have my visa just at the last moment. So thank you very much for everybody. Cognitive impairment after strokes, I will just detail the risk factors and also the mechanisms and not speak at all of treatments or prevention except 1 or 2 slides at the end. So you know that in the world approximately 15 million strokes will occur every year. Of these 15 million strokes, approximately 1/3 will die and 2/3 will survive. So we have 10 million survivors, and of the 10 million survivors, half approximately will be left with disability. And a big part of the disability is the consequence of a cognitive impairment, and the major type of cognitive impairment, which was called in the past dementia, and I will still use the term dementia in my talk, but we call it now major cognitive impairment. Besides, we have also many patients, we don't know exactly how many because it's more difficult to have strict criteria, who have cognitive decline without dementia. These patients may, for some of them, be called patients with mild cognitive impairment. And these patients, of course, are those at risk to develop dementia in the future. But we have to bear in mind that this is true for strokes. Stroke patients we know who arrive in stroke units with hemiplegia, with aphasia, and so on, sometimes with a quick recovery. But besides these patients with a clinical picture of stroke, you have also many more patients who never experience a stroke, but have actually stroke lesions in the brain. If you perform MRI or sometimes just a CT scan, you will see that many of these patients will have silent infarcts, microbleeds, white matter changes, and so on. So bear in mind that besides patients with a stroke, we have also many patients without clinical evidence of stroke who have vascular lesions in the brain. This is just to remind you that when somebody develops cognitive impairment, dementia, after a stroke, in many many kinds of patients, you have already some degree of cognitive impairment before, and sometimes even dementia before. And this is a meta-analysis of 3 studies conducted in Poland, conducted in... no, if you can hear me, yeah. And conducted also in the My Center in Lille, in the north of France. And you can see here that in patients who are admitted in the stroke unit for an acute stroke, approximately 15%, a little bit less than 15% of these patients were already demented before. We have tests that allow us to identify if patients were already demented before, even if they never attended a memory clinic before. So for patients admitted in stroke units in hospitals, approximately 15% were already demented before. And if you look at the population now, of course, not all patients are admitted in stroke units. You have some patients who are not. And the proportion of patients with dementia before stroke is a little bit lower at the population level, but it's around 9%, which is not so bad. And these data come from all studies. These studies were conducted in the 90s. The life expectancy has increased by almost 7 or 8 years since the 90s. So now we have probably many more patients who are already demented before a stroke. What happens after a stroke? It depends if it's a first stroke or a recurrent stroke. In blue, you have patients with a first ever stroke, and you can see here that 1 year after a first ever stroke, of those who were not demented before, approximately 7 or 8% will be demented 1 year later. So having a stroke is clearly associated with a risk of dementia, even for those who were not demented before. And this will increase over time, and you can see here that after 5 years, you have something like 15%, a little bit less than 15% of these patients who will be demented. If you look at the red part of this plot, for instance, now, you have patients with all kinds of strokes, including not only first ever strokes, but also patients with recurrent stroke. And you can see here that the risk is much higher. So having a stroke is not a good news for the cognition, because the risk to be demented in the future is very high. But after having a recurrent stroke is even worse, because you can see here that after a recurrent stroke, the risk to be demented after 1 year is not far from 25%, 1 out of 4. And after 6 years, it's almost 40% of these patients. Taking into account that after 6 years, many of these patients are dead, and those who died are probably those who are the highest risk to be demented. So this is really a big problem, and this emphasizes the need for the prevention of stroke recurrence. We should prevent a first stroke, of course, but we should also prevent a recurrent stroke. So this is to explain why this is a very important public health issue. These are the figures coming from my country, but I think it's almost the same in all European countries. You know that our life expectancy has increased. Just after the war in France, the life expectancy of a man was around 60, and of a woman, I think it was 65 or something like this. And currently, we are approximately at 80 for men and 85 or 86 for women. So the life expectancy has increased, and this explains why we have now a huge proportion of the population who is over the age of 70, 75, I mean over the age at risk for stroke and for dementia. This is the first phenomenon. But we have on top of that another phenomenon explaining why we will have to face more and more strokes and more patients with cognitive impairment. That is what we call the baby boom. After the end of the last war, during the following 30 years, we had a huge increase in natality, in birth rates. And I am one of these baby boomers, but many others are of these baby boomers. And the baby boomers are now becoming puppy boomers or mommy boomers. because they arrive at the age at risk for stroke and at risk for cognitive impairment. So on top of the good effects, which is the increase in life expectancy, you have another phenomenon which will not stay over time. This second phenomenon will disappear, but not in the close future. This other phenomenon is a kind of tsunami. It's a wave, and as all waves come and disappear after. It's just because of these people, the baby boomers, who are in the age at risk. Approximately in 75, 80, these people will have disappeared, and of course we will just go back to the aging of the population if in the meantime we have no drama, if we have no epidemic, no war, and so on. What are now the determinants of post-stroke dementia? So is it possible when we are facing a patient with a stroke in the stroke unit to say this patient is really at high risk to become demented in the future? This comes from a systematic review we published in the Lancet Neurology 15 years ago. And I have put on the slide and on the next one only factors that have been identified in at least 2 different studies, 2 different populations. There are many other factors, but sometimes identified only in one study. They are not here. You can see here that we have many factors depending on the patient. It's not a surprise to know that those who are more likely to become demented are those who are older, those who have a low education level, and this has something to do with the cognitive reserve, those who were dependent before, but very often when somebody is dependent, it's for cognitive reasons, those who have the so-called cognitive decline, no dementia. Some of them can be called mild cognitive impairment. Those who have vascular risk factors, and also a series of factors such as epileptic seizures, pneumonia, and so on, which are more frequent in those who will develop in the future dementia. These are factors in relation with the patient. You have also factors that you can detect only on MRI, only on imaging. Having a silent infarct, a global cerebral atrophy, a medial temporal lobe atrophy, white matter changes are also frequently associated with an increased risk to develop dementia in the future. And finally, we have factors in relation with the stroke itself, and I will not go into detail, but just to make things short, I have to say that those who are more likely to develop dementia after a stroke are those who have a more severe stroke. This has been shown in different studies, and also those who have supratentorial infarcts, which is quite logical. In the posterior fossa, if you have a stroke, the risk for cognition is much lower, except if you have 2 lesions. And those who have multiple lesions or lesions located in a strategic area, such as a thalamus, for instance. This was quite old, and more recently, you had a very nice study published in the Lancet Neurology. It was at the end of 2019, published by the group of Peter Roswell in Oxford. And in these studies, they have clearly shown that those patients who have the highest risk to develop dementia after a stroke are those who have most severe stroke. In the lower part of this slide, you have patients with TIA. So you see that after a TIA, there is a risk to develop dementia in the future, but there is a risk also even if you have no vascular event. The risk is lower. And the other part of the graph show exactly the risk to be demented depending on the severity of stroke. It's classified by a score at the NIH score. And the more severe is a stroke, the more likely is a patient to be demented. And for instance, for those who have a NIH score higher than 10, you can see here that after 1 year, the risk is already 40%, which is very important. So clearly, there is a link between the stroke, the severity of stroke, and the risk to be demented. And this is true in all age categories, but of course, the weight of the stroke itself is much more important in young people. When young people develop dementia after a stroke, it's much more likely to be directly the consequence of the stroke than in an elderly patient who is 95 and develop dementia after a stroke, but maybe also because this patient has other lesions of the brain, other vascular lesions, or Alzheimer's lesions, for instance. So it's more frequent in severe strokes, and it's more frequent in elderly patients, but the weight of stroke itself is more important in young people. So what are now the clinical situation we can face? What is the cause of the vascular cognitive impairment, or the dementia, which is the top of the vascular cognitive impairment? The first situation is when the patient becomes demented after a stroke because he has a stroke or she has a stroke, when it's directly the consequence of stroke itself. This is what we will see in young people. Young people with a stroke who becomes demented, it's likely to be the consequence of stroke. It's more likely when you have a clear clinical situation, CADASIL, for instance, genetic disorder in young people, we know the cause. When the patient has multiple lesions of the brain, and also when the patient has strategic lesions, for instance, a bilateral thalamic infarct. In this case, we know that the risk for the cognition is much higher. And we have summarized all of this in a review published 4 years ago now, 3 years ago, with Martin Dischgens from Munich in Circulation Research. Vascular sometimes may mean silent infarcts. You know these silent infarcts? When we perform an MRI to somebody for any reason, sometimes we can find an infarct, and there is absolutely no clinical event that could explain this infarct. So they are more frequent if you use MRI than CT scan, of course. We are not so sure they are silent, because some of them may be led to TIA, but during the night, or sometimes some of them may lead to TIA, but in a right-handed person, so it did not identify. And of course, if these lesions lead to cognitive impairment, they are not really silent. The infarct is silent, the event is silent, but the consequence is not silent because of the risk of dementia. These silent infarcts are well seen in our usual MRI machines. Usually we use 1.5 MRI machines, sometimes 3 Tesla. But if you use 7 Tesla, there are not a lot of 7 Tesla machines in the world. This is coming from Utrecht, for instance, in Netherlands, not far from where I live, but with 2 borders between. And you can see here very small infarcts in the cortex of the patient that can be detected only with 7 Tesla machines. So the highest the field of MRI, the highest the chance to identify an infarct on MRI. So silent infarct may contribute. Another contributor is white matter changes. This has been called by Ashinsky leukoariosis. It was described as leukoariosis on CT scan. Now we use more MRI for that. We know that this is very frequent in normal people, but usually in normal people with risk factors, especially high blood pressure, but not only high blood pressure. It's usually a marker of small vessel disease, frequently associated with lacunes, with microbleeds. And we know that this is frequent in patients with arteriolosclerosis, with high blood pressure, for instance, in patients with genetic disorders such as CADASIL, and also sometimes in patients with large vessel disease, when the large vessel disease is associated with an occlusion of a deep perforator. So you have a disease in the large vessel, but the consequence is for a deep perforator. Does this white matter change lead to cognitive impairment? We don't know exactly. I will show in a future slide that atrophy contributes more to cognitive impairment than white matter changes. But what has been shown in this systematic review is that somebody who is not a patient, a normal person, who agreed to participate as control in a study and has white matter changes, these people have an increased risk to develop cognitive impairment in the future compared to those who have no cognitive impairment, even if you adjust on the blood pressure, ApoE4, and so on. So having white matter changes does not mean that the person will be demented. Most of them will not be, but it's a marker of an increased risk to be demented in the future. Microbleeds. Microbleeds is frequent. This is coming from a systematic review performed by somebody of my group, published in Brain more than 10 years ago now, showing that in the population, 5% of people have microbleeds, especially old people. It's more likely to be seen in those who are admitted for ICH, intracerebral hemorrhage, and it's more likely to occur in those who have a recurrence. So these microbleeds have been shown to be frequent in memory centers, and Charlotte Cordonnier, who performed this systematic review and published in Brain, went to the memory center of Amsterdam. Why Amsterdam? Although we have a memory center, because Amsterdam used MRI for Alzheimer's patients for 30 years. So they had a huge amount of data on that. And she has shown that microbleeds were much more frequent in those with vascular dementia, but also that microbleeds were more frequent in patients with Alzheimer's disease compared to controls. And controls in this study were people with just subjective memory complaint. We know that in these patients, a few will develop Alzheimer's disease, but most did not. And finally, the last factor, vascular factor. It may be surprising to classify atrophy as a vascular factor, but we know now clearly that vascular lesions of the brain may lead to atrophy, and this has been clearly shown in CADASIL, for instance, which is a pure vascular disorder. It's not a degenerative disorder. And it has been shown clearly that of all these MRI markers, silent infarcts, microbleeds, white matter changes, and so on, the one who is the most related with cognitive impairment is cerebral atrophy. Not only medial temporal lobe atrophy, which can be a marker of Alzheimer's disease, but also global cerebral atrophy. And this is something very strong. I don't know any study evaluating atrophy, even sometimes just by CT and just by a subjective rating scale with a classification in 4 categories, which is very easy, very simple. I don't know a single study sufficiently powered that did not show atrophy as associated with cognitive impairment. In CADASIL, for instance, it's clear that the marker that is the most related with cognitive impairment is cerebral atrophy, not white matter changes, silent infarcts, and so on. This is the first mechanism. We can become demented after a stroke because we have stroke lesions in the brain. This is simple. There is a second mechanism that is possible because we are speaking of patients who usually are old, and in elderly we have a risk of stroke, but we have also a risk of having Alzheimer's disease, and both can be associated, of course. And this is an hypothesis we made almost 25 years ago with my colleague from the Memory Center, Florence Pasquier. Our hypothesis was the following. If you have Alzheimer's lesions in the brain, you know that people who have Alzheimer's disease have a long history, 20, 25 years, when they accumulate Alzheimer's lesions in the brain before they develop the disease. If you have a small stroke, a lacune, for instance, at this stage, when you are just at the preclinical stage of Alzheimer's disease, the result will be that you will start your Alzheimer's disease maybe 3 or 5 years or 10 years earlier than you would without a stroke lesion. And this was our hypothesis, that a small stroke lesion could anticipate the onset of Alzheimer's disease. And I have to say that this hypothesis, I will not go into detail, but this hypothesis has been confirmed by many other studies. The NUN study, you have probably heard of this study, very old, 25 years or so, published a little bit after our paper, a study conducted in Catholic nurses in the US, and they agreed during their life to have cognitive tests, I think it was every 6 months, and to give their brain for science after their death. And it was shown in these nuns that for the same amount of Alzheimer's lesions in the brain, those who were more demented were those with vascular lesions in the brain. So that is clearly a summation of the two types of lesions. And after we had other studies showing the same, this has been shown, for instance, in Honolulu, it's exactly the same principle. If you have a certain amount of Alzheimer's lesions in the brain, the presence of vascular lesions will make patients more demented than the absence of vascular lesions. So the summation is important, and this is my only slide on treatment, because treatment will be treated by Ala. But just to show that this has some consequences. Here you have the result of a very old trial. Nobody would reproduce this trial for ethical reasons now. It was a trial conducted in elderly people with a systolic, pure systolic hypertension. And these people were randomized placebo or active treatment. Active treatment was nitronidine. It could have been another one. I think the results would have been the same. And it has been shown in this trial, it has been mainly shown that when we treat hypertension, even in the elderly, we prevent MI, stroke, and mortality. But it has been shown also that we prevent dementia. And if you look at the type of dementia prevented, we prevent Alzheimer's disease. Nobody will reproduce this. For ethical reasons, we cannot give a placebo anymore now, 25 years later or 20 years later, in such patients. At this time, it was possible because we had no proof of efficacy. Of course, the results relied on very small amount of people, but this is the only positive trial with a treatment, and I think it will probably always be the only one, because now we have to compare two treatments. We cannot compare with a placebo, so it will be difficult to show another effect. So this is going in the same direction that what was our hypothesis. And finally, besides the role of vascular lesions, the summation between vascular and Alzheimer's lesions, there is another hypothesis, which is probably true also. The hypothesis was made by Costantino Iadecola, who is an Italian neurologist who lives in the States for 30 years now. And he has shown, I will make the story short, he has shown clearly that there is also an interaction between vascular lesions and Alzheimer's lesions. So the association between the two diseases is not just an association, it's not 1 + 1 makes 2, it's 1 + 1 makes 3. So there is a summation and potentiation between the two types of lesions. And this is the following pathway. If a patient has vascular risk factors, these vascular risk factors will lead to ischemia in the brain or in the heart, but at the end, it will modulate the amyloidogenesis and induce changes in the neurovascular unit. And if somebody has Alzheimer's pathology, for instance, for genetic reasons, in this case, of course, you have an amount of A-beta peptides, and these A-beta peptides has vascular effect, and at the end, you have exactly the same consequence. So you can enter the malady, the disease, I'm sorry for the French name, you can enter the disease by the vascular risk factors or by the Alzheimer's pathology, and at the end, you have a cognitive impairment. Finally, and this will be the final part of my talk, we can make the hypothesis that we don't need always to have a link between the vascular risk factors and the cognitive impairment, that is a stroke. Until now, we considered that we have vascular risk factors, they induce a stroke, and the stroke is associated with cognitive impairment because of the stroke, because of the summation with Alzheimer's lesions, because of the potentiation between two different diseases. But our hypothesis is now that you can have a direct connection between vascular risk factors and cognition without necessarily a stroke in between. And you can see here that if you consider people as a reference, people who have no vascular risk factor, normal blood pressure, they don't smoke, they have a normal cholesterol and so on, when you have arterial hypertension, when you have arterial hypertension, you increase your risk by 40%. When you smoke, you increase by 300%. Thank you. When you have diabetes, the risk is multiplied by 3. And when you have a combination of 3 risk factors, you have 18-fold increased risk to be demented in the future. So clearly, there is an association between vascular risk factors and dementia. And this has been proven in Sweden in the 80s or early 90s. Patients who are recruited in the 80s and published in the 90s from the study from Skog in Gothenburg, showing that people who have a high blood pressure at the age of 60, 55 or 60 are patients who have a higher risk to be demented 15 years later. But if you look at the type of dementia they will develop, you see that they can develop vascular dementia. This is quite logical and expected. You have hypertension, you have vascular dementia at the end, but also of Alzheimer's disease. And this was not expected, that high blood pressure at the age of 60 was associated with a risk of Alzheimer's disease 15 years later. Case control studies did not show this before, but just because when the disease evolves, when a patient has Alzheimer's disease, the blood pressure usually decreases. So if you perform case control transsectional studies, you cannot show the effect. This effect can be shown only if you follow patients, if you follow not patients, but normal people over time. This has been shown for high blood pressure. I will not go into detail, but this has been shown also with cholesterol. Something is wrong. Maybe you can help me for the next slide. Oh, it's okay. Now, if you can go backward one. Maybe this one is not working anymore. So we have mechanisms which are not dependent on the stroke, but are clearly dependent only on the vascular risk factor. And now a part of our research is to understand why. For hypertension, for instance, we have explanation. We can imagine that if somebody has a high blood pressure, this leads to a constriction of the deep perforators, and this chronic ischemia may induce amyloidogenesis and so on. For diabetes, for instance, it has been shown that insulin modulates tau proteins phosphorylation, and you know that tau proteins are a major contributor to the lesion of Alzheimer's disease. So my conclusion is the following. It will be a little bit more than a conclusion. There is a frequent association between stroke and cognitive decline, or the top of this, which is dementia. It may be the consequence of the vascular lesions, but not only. Stroke and Alzheimer's disease are age-dependent, so it's not just by chance if we have the association of the two. They share similar risk factors. There is an additive effect between the two diseases. There is a synergistic effect. And now we are at another stage, and we are exploring the fact that having vascular risk factor could be, even without stroke, associated with an increased risk of dementia and even of Alzheimer's dementia. This is important, and this will be a link with the next talk, because if this hypothesis is true, that means that if we treat correctly, and we heard yesterday morning that we should not smoke, we should not drink, we should not eat too much, we should walk, and so on. But if we treat correctly, properly our risk factors, in theory, we should be able to decrease the risk of having vascular cognitive impairment and dementia. And the last part of my talk, I finish just after, is on the right. It's an optimistic way to present the things, because you know that in the population, we have more and more people with cognitive impairment and with dementia, mainly because we have more and more people who are over the age of 90, 85 or 90. But if you look, and I have just shown the result of a British study, but we have exactly the same in Canada. If you compare the risk to develop dementia, not at the level of the population. At the level of the population, it's clear that we have more people with dementia now than 25 years ago or 50 years ago. But if we compare by age category, so you compare your risk with the risk of your parents and the risk of your grandparents, it's clear that this risk is decreasing. For instance, here, people over the age of 80 nowadays, of course, have a high risk to be demented, but this risk is much lower than the risk of their parents and of their grandparents. What are the differences between the two populations? Between my parents, my grandparents, what was the major difference? We had two major differences. First, we can now treat vascular risk factors. That was not possible. The first treatment of high blood pressure was in the 50s. So it was not possible for the generation of my grandparents, people born in 1905 or something like this. Now we can. And there is another difference we should take into account also, and probably Ala will speak of that, is the level of education. The level of education in all European countries has increased a lot during the last century. And we know that with a higher level of education, the risk to be demented is lower. There are other factors, hygienic factors and so on. So that does not mean that it's only the effects of treating vascular risk factors, but it's likely that this contributes to the decreased risk of dementia we see nowadays. Thank you very much.
Thank you very much, Professor Rees.
I'm not sure it works.
For an excellent presentation. We are ready to listen to you for an hour. It's a great pleasure for us. But because of the lack of time, I'll ask you only one question, please. Can you tell us, is it useful to make genetic consultations in people, in elderly people, in younger people, because the genetics made a great progress and it became not very expensive for people? What do you think about it?
I think it's a big ethical problem, because to say to somebody, you are at high risk to be demented in the future, it's important if we can prevent dementia in these people. And the only thing we can do now to prevent dementia is to treat risk factors, but this is recommended for all of us, even without the risk of being demented, and to train the brain, so I mean to have a high level of education, to speak at least 2 languages. We know that people who are bilingual at a lower risk than people who speak only 1 language, for instance. But this is something which could be advised. So currently, in the absence of a clear treatment, I think we could not recommend outside a study, for instance, to perform this genetical test. We will say to the people, you should treat your blood pressure, but anyway, we have to say this. This may change if we have a treatment, and this may change especially if we have a treatment which is dangerous, or a treatment which costs a lot. Because in this case, if there is a danger of, if the cost is high, of course we should not offer this treatment to everybody, but only to those who are really at high risk. Even if we have a treatment which is easy, does not cost anything, a kind of aspirin, I'm not saying that it's aspirin, but a kind of aspirin, even in this case, I think it would be ethically disputable. For instance, in the EU currently, we cannot perform, everybody can perform an ApoE, for instance. It's easy. If you have ApoE4, you have high risk to have Alzheimer's disease. But it's not allowed except for trials. And even in trials, the doctor and the patient will never know the results. It's just for scientific reasons, and will link ApoE genotype to a patient who developed or who did not develop a disease, but we don't know exactly what is the result for our patient, for ethical reasons.
Thank you very much, Professor Leis, and we hope that treatment will come very soon. А сейчас, уважаемые коллеги.
And now, dear colleagues, I'm going to give the floor to Professor Alagacht. Dear colleagues, dear Renat, dear Professor Didier, I will naturally speak Russian, but we wanted to have an interactive discussion between the two speakers. Therefore, part of my slides will be in English. Otherwise, it will be quite difficult for my colleague since he doesn't speak Russian. I think that by your next arrival, you will absolutely learn Russian because Russia and France are closely linked between each other. So next time, Professor promised to speak Russian, right? First of all, I would like to extend my gratitude to the Mayor's Office and to the Healthcare Department for the organization of this amazing event. Indeed, the Assembly is very interesting, and it's a great pleasure for us that our center had the honor of organizing several events as part of this Assembly. As you saw on the video, we are proud of friendship and good contacts with our foreign colleagues. And tomorrow, Professor Galviani will present an amazing program on myoclony that will start in Sklifosovsky Hall at 1:30 p.m. Then we will have a number of presentations on behalf of our center. So please come. As far as I understand, not everyone managed to make it here today, and that is why I would like to announce that we are going to have a conference on the 1st and 2nd April. It will be open to the public, and books will be distributed there. You can have all the information in the brochures, or Renat can give you the details. Now we are going to speak about vascular cognitive impairments. Oh, by the way, I forgot to say one thing. Renat made an introduction of myself and Mr. Leis, and I would like to introduce our moderator, Renat Akhzhigitov, Deputy Director of the Psychoneurological Center of Solovyov. He was recognized as the best psychiatrist last year, right? Of Moscow. And as you can see, our center has a close collaboration between psychiatrists and neurologists. This is a must today, so that we could treat cognitive impairments as well as emotional distresses and a number of other troubles. We are going to have a brief discussion of epidemiology and burden of cognitive impairments. Professor Leis's lecture about the risk factors was very interesting. We are also going to speak about the risk factors a little bit indeed, but also about prevention, non-medicational methods and pharmacotherapy. Professor Leis has already spoken about figures. Unfortunately, I cannot really show figures on the slide. The equipment is not working very well, but still, you can see on the slide that now in the population we have, in Europe, for example, 20% aged more than 60, and a small percentage of people older than 80. There is a fraction of such population, but we will see that in 2100, 30% of the population in the world will be older than 60 years old, and nearly 10% of the population will be older than 80. And even in Africa, where today only 1% of the population is older than 80, there will be around 6% of population older than 80. And that's very good because the wisdom of the elderly people is precious. On this slide we can see the breakdown of the world population by age. If we look at Africa, people over 80 are even not reflected on the graph, but very soon we will have 6% of population in Africa older than 80. Of course, all of that is related to the change of pattern of providing care. In Moscow, for example, we now have the active longevity program. In addition, our center is treating cognitive diseases. The goal of all of that is to ensure good health and well-being of the elderly people in a short time. Here we can see a line in violet. This is the line showing population over 65 years of age. This is the fastest growing part of the population. And in addition to cognitive impairments, there are many other diseases that affect that share of population. Here again you can see how quickly the share of elderly people will be growing all around the world. On this slide we see the increase of the population over 65 years of age. This share is increasing every year. The dark blue shows people over 65 years of age. So we are going to witness a significant increase in the population of elderly people. This is a picture that was recently published in Lancet by Professor Fagan and many other colleagues. Here we can see the global burden of disease. The dark violet shows cerebrovascular disease, lighter pink shows Alzheimer's disease. So these are the conditions that affect elderly people, and in the upcoming dozens of years, the burden of these diseases will increase. And some economic factors. We see that stroke, dementia, and mood disorders represent a high burden. You know that dementia is often accompanied by depression and vice versa. These are the conditions that are economically significant. And of course, I should mention that the WHO pays a lot of attention to that. There is a program related to dementia that was developed by WHO. Several years ago, Geneva hosted the first global WHO Minister of Foreign Affairs level conference about a healthy lifestyle and fighting against non-infectious diseases. This is very important, and Russia was among the key initiators of this conference. There was another conference that took place in Moscow, Russia, and that was the beginning of addressing non-infectious diseases. Another event related to WHO is the following. You know that stroke is still amongst cerebrovascular diseases in ICD. When we are coding, it doesn't matter how to code, but when we do the global analysis, the burden of stroke goes to the burden of cardiovascular diseases. Although we know that stroke is a brain condition. And after 60 years of this wrong classification, at the initiative of a number of biggest experts in the world, Professor Lace was in this group, Professor Primel, Professor Kaczynski, Professor Ralat Shakir, who was back then president of the World Neurologist Association. That was quite difficult, and a decisive role was played by a letter of the Russian Federation that said that Russia thought that stroke should belong to these cerebrovascular diseases. So now stroke belongs to the neurological condition group. There is also the WHO Global Action Plan against non-infectious diseases. It's a pleasure for us that our center is taking an active part in it. We all are organizing cognitive schools in our center in collaboration with the WHO, and this collaboration will further expand. That's what Professor Lace has mentioned. Neurodegenerative components and vascular components are always in interaction in the genesis of dementia. And we are going to speak about that when speaking about the therapy targets and risk factors. This is a picture that is similar to one of those that I have shown you. Vascular dementia represents now over 16% of all dementias, and incidence of dementia after stroke is quite significant. It has been proven in population studies that are shown in blue here, as well as in hospital studies. We can see some figures. This research was published in Lancet, and its author is Professor Lace. That's why it's a particular pleasure for me to speak about this research. We know that 5 years after stroke, around 20 or 30% of patients have significant cognitive impairments. So the issue is huge indeed. It's a global problem, and there is a huge number of patients who have mixed dementia. I'm going to skip some slides for the sake of time. Some points that I'd like to draw your attention to. Of course, recovery after stroke, motion recovery, speech recovery is very important. As of today, we have quite a lot of data showing that even in case of good recovery, as we can see here on the slide, so even in case of good neurological recovery, a large part of patients still has issues. In some populations, it's up to 30 or 50%. These patients have pronounced cognitive impairments as well as emotional impairments. So again, it's very good when patient starts walking. It's a true happiness because it reduces the burden for the family and the patient himself. But we often are not testing the patient as he should be tested, so we may underestimate the cognitive impairments. And at this stage, when not a lot of time passed after stroke, if we apply some preventive and treatment measures, we can actually help patients. And another thing, reperfusion is a great achievement of the 20th and 21st century in the treatment of stroke. But there is a number of papers that show that cognitive and emotional impairments the clicker is not working. Oh, finally. So, cognitive and emotional impairments are preserved in a large population in about 20 or 30% of cases, even in patients for whom reperfusion was a success. So this is a problem that requires a lot of attention. Now, I'd like to speak in greater detail about the risk factors. When we were talking with Professor Lace, we were complementing each other. Again, how do you think, what are we doing now? We are not just discussing cognitive impairments. Actually, we are preventing our own cognitive impairments. because lack of education, low education, lack of brain activity is one of risk factors that can lead to faster development of dementia. One of our colleagues that we know very well with Professor Lees, we are going to talk about him. He will come to see us in April. It's Emma Scorchi. When his mother started having memory impairments, I asked him, how do you treat her? He answered, when I noticed memory impairments and some other impairments, I taught her to play bridge. As far as I know, it's a complex game. Anyway, I didn't manage to learn it, but it is a true training for brain. And what's also crucial is the family attention, living in the family, having the family warmth and care. It has a social significance because social significance are as important as neurobiological ones.
If we speak about pre-stroke impairments, they are also very important, and we also saw the trajectories. And here you can see also the factors associated with post-stroke cognitive impairments. Also, very important factors which have, also interconnected thing. This is the change of walking. So this is for patients who develop impairments quickly, but again the exercises can prevent this. Also there is a connection between epilepsy and vascular dementia. What is interesting here? Alzheimer morphological impairments, these plaques were detected, and I found this work. In 1892, it was issued. Elderly people, elderly patients had late epilepsy. Epileptic patients, and I found this work, and there is connection. And in one of recent works, also there is information. We can see a lot of polymorphisms which are connected with epileptic states of elderly dementia, risk factors. All these are interconnected, and here we have a lot of common genetic and pathogenetic factors. And of course, a lot of research in our center shows inflammation mechanisms participate in this. But this is a separate lecture, because now the mechanism of inflammation is paid attention to. Also, we speak about interaction between vascular and metabolic impairments. And our group is also busy with this. We speak about severity. And in this part, I would like to say that this is not only cerebral disease, but these are a lot of factors which can be related to development of atherosclerosis and heart diseases. These are the same impairments of the whole organism, not only cerebral impairments. And Professor Leys spoke about placebo-controlled research, but the group of patients who receive placebo also behave differently if they have Alzheimer dementia and if they have vascular dementia. For example, if a patient is under research, and also we have a term even which characterizes this, this general supervision, risk factors control are better. and the patients with Alzheimer's dementia is worsening, and patients with vascular dementia are relatively stable. And also, this is the book of James Toole, professor with Gusiev academician. We reissued this book in Russia, and there were a lot of chapters. Also, some of them were written by our scientists and also by foreign scientists. What about prevention? We'll look through these factors, and we'll start with Galliano and Hippocrates. So Galliano showed that dementia, this is impairment of brain, and it's linked with dysfunctions of many other systems of the organism. And now it's widely spread. This reference to China, and this is a very interesting research which shows a lot of ways how to treat dementia in Chinese medicine. For example, some herbs, ginseng, some part of ginseng. We never try to do this, but in many works and also in China, scientists conduct this research. We also have ancient Chinese recipes, and in these recipes there are some positions even of modern pharmacology. Maybe this can be also of some use to us. And Esquirol book, the causes of dementia. The book was written in 1838, and also the article about it was published in 160 years. And I liked this article very much. At the beginning, so there was such an attitude, what they could read 160 years ago. But then, when we start to read more attentively, we understand that also it can be quite helpful. We spoke about menstrual cycle, which is linked with hormone changes, and also brain traumas. I think brain traumas influence a lot on impairments, and I know that also age, fever, and infections. Then the role of stroke, also we spoke about it a lot. And even unhappy laugh. We speak about neurobiological mechanisms, combination of depression and dementia, and this is unhappy laugh. So, all the doctors without MRI, without CT, could see something what we only see with these things. What can we do with this? You can see change of lifestyle, diet, sociological factors, and now let's speak about each factor. This is a good research which was conducted by Michael Bryan, and he split several groups of patients. One group conducted good lifestyle within some period of time. And formally, there was no difference between the main group and the control group. And we can say that maybe it's not true. But this example shows how careful we should, what careful attitude we should have towards the research. This was for Austrian population having mild strokes. People with recurrent strokes were excluded from the analysis. And we know that lifestyle can influence on recurrent strokes. Also, the decline in executive function domain was found less often in the intervention group, whereas its frequency doubled in the controls. And this analysis showed that we have sufficient grounds that healthy lifestyle is very important. Another concept which is in focus now, this is the concept cognitive frailty mechanisms. And here we can see a lot of mechanisms, factors of life, cardiovascular factors have an impact on cognitive impairments. And also they say a lot about nutrition. Some people say that a person is what he's eating, you know. Of course, maybe it's not really true, but still there is some sense in it. The investigation, this research was published in Lancet, Nutrition and Prevention of Cognitive Impairment. Now they speak a lot about antioxidants, vitamins. This research is open, so you can easily find it, and will not look at this picture in details. I just want to say about the first graph. The first graph, this is observations, and the second graph, these are clinical trials. Highlighted by green, these are positive effects proved. Highlighted by red, negative effects, and blue, so neither fish nor fowl. And among this enormous group of factors, nutrition factors, only 5 can be evaluated in normal clinical situations. If there are more green lines, this is Mediterranean diet. And the other this article was published last year, but I don't think that something radical changed. So when we say that this tablet will work wonders, or this biological added supplement will make miracles, we don't have any proof of this. The only thing which makes sense, and many factors show this, so makes sense. This is Mediterranean diet. But you can see the characteristics of the diets. Physical activities. On the one hand, we say yes, it's very important to do morning exercises, to do physical activities. But again, the article was published last year, 2018. Not last year, but 2018. The role of exercises in lessening of severity of dementia. And there is proof that a lot of things, a lot of risk factors change, executive functions change, and the cellular factors change. And today we hear about healthy lifestyle, about walking, bicycle. These all have a clear neurobiological nature. When we speak about neurotrophic factor, we know in 38 Nobel Prize was given to this. This is very important for integration of metabolic response. There are a lot of mechanisms which connect a lot of issues, BDNF, and here we speak about survival of organisms, and neurotrophic factors, including BDNF, also are a reflection of healthy lifestyles. Very interesting research was published. A group of people with low level of BDNF, so people who lived in comfortable environment without any problems, comfortable conditions, practically never faced difficulties of lives. And then this Spartan healthy lifestyle. But this Spartan healthy lifestyle leads to survival. We know about Spartans and how they fought. So the level of BDNF also has a sufficient mechanisms, biological mechanisms, and there are two polymorphism of BDNF, so if so, for example, also some kind of polymorphism variant is linked with high risk of suicidal behavior. And we are doing this also in our researches, in our groups, and this makes sense. Also modified factors of risks, modifiable. And here we can see the percentage of incidence which is linked with this risk factor. Or maybe it can be removed if this risk factor also will be removed. We can see diabetes, obesity, hypertension, smoking, physical inactivity, 14%. Of course, it's clear that this is modifying research. 14–15% of dementia. We can make it less if we remove smoking, physical inactivity, and 20% not enough education, 9% depression. So once again, risk factors are important and we should pay a lot of attention to them. One of the non-medical method, magnetic stimulation, but we don't have time for this, and also pharmacological prevention and treatment of vascular dementia. Now we have some proofs. First of all, I don't speak about the secondary prevention. Of course, this is alpha and omega, and we'll never finish if we start to speak about this. And the whole range of big research was dedicated to inhibitors of cholinesterase and memantine. There are issues whether their role is proved regarding vascular dementia, because you know, a lot of research was dedicated to Alzheimer's dementia, but they have a lot of side effects. We spoke about fragility. Our dementia patients, they are quite fragile. Not always it's possible. The good proof they have this research, but also a high percentage of adverse effects. Memantine has very good tolerance. Patients have very good tolerance towards this. But again, if we speak about proof and influence on proof, of course, there is a long way to go. What else would I like to mention about? You know this story that memantine has quite a strange mechanism, but this mechanism is linked with the change of BDNF concentration. And also we have a wide list of other medications, also antidepressants, and also anti-inflammatory medications, which are also linked with some other factors. And this is one of the mechanisms. This is the work which we executed with one of the students of Lay's professor, Baudet professor. We tried to understand whether we have the possibility to conduct therapy which can influence on disease. So is there something which can be disease modifying, and we discussed some different medications, and in this article we touched upon neuroprotectors. We published this with Skoog professor, and this is some kind of conclusion. I'm interested in Professor Late's opinion. We know that in many countries so these medications are used, but in France and Finland they are not used, and in many other countries they are used. But there are pros and cons of using these medications. We published some research. They were published together with our foreign colleagues and in good magazines. So the first work is not our work, but we used it as a model. Cerebrolizine Alvarez, a professor on efficiency of this medication if a patient has Alzheimer's disease, and our research was published in 2011 in the magazine of general stroke and vascular diseases, and here we showed a sufficient increase of cerebrolizine influence in comparison with placebo, and we had a representative group. You can see there are two periods where we prescribed this cerebrolizine medication.
The results were not the results that could prove the possibilities, as the design was not perfect. However, the accuracy level was quite high. What's also very interesting and what was very pleasant for us is that the Cochrane review was published at that period. However, everyone knows the significance and the accuracy of Cochrane reviews. And finally, our review, no issues about methodology of this study, so at least we could yield some results from it. This is again a meta-analysis and the responder analysis. The meta-analysis had quite a good conclusion. Quite recently, together with Morishon, Professor Barnstern, we published another study on recovery after stroke. You are probably well aware of it. In ARAD scale and NIH scale, we witness positive dynamics. However, this is not part of our subject today. However, we see many other cognitive scales that have shown also good dynamics. Another research is Artemida research. You are well aware of Activigin. You know what it is, and we wanted to resolve all the methodology issues at the level of design. This research was published 2 years ago in Stroke Journal. Again, this is a double-blind, placebo-controlled study. We see the incredibly positive reaction at ADAS-Cog scale after 6 and 12 months, so it's highly credible, and the dynamics is good. What's interesting is that now, together with our foreign colleagues, we are conducting a study once again, and this is the placebo group. So this is kind of a natural flow of the disease. For placebo, there are no metabolics, and we see that the situation is more stable for more elderly patients. For patients younger than 65 years of age, the situation is less stable, maybe because the initial level was different, but again, in the absence of therapy, this is what we have. It is interesting to see these different dynamics in different age groups, taking into account the increase in secondary prevention. And we see different conduct of these patients, especially elderly ones, which highlights once again the results of the study. We have been talking a lot about the risk factors. We scrutinized the subgroups, and it turned out that the medicine was more effective in patients who did not smoke and in patients who were non-diabetic. Soon it will be published. But again, if we are speaking about the impact of medicines, healthy lifestyle, of course, has a positive impact. Of course, the matter of neuroproducts remains. And very briefly, what are the other possibilities? There have been several studies of ginkgo biloba. They are quite limited to compare with the previous studies and with the other studies discussed, and further research is needed. There have been a lot of good studies of vinpocetine, but the population of patients was quite small. However, it does have some positive results. There were several limited studies of ceticoline. What's also important is that when we analyze the results, we see on these examples that cognitive impairments is not just related to depression or the change of style, but also to the fact that the patient is not compliant anymore. So that's a vicious circle. And this once again highlights the necessity for such patients to live in a family, because in case of non-compliance, secondary prevention is impaired, hypertension treatment is impaired, and a number of other factors related to patients suffer. Some new areas of research, of course, do exist and will develop. There is a number of anti-inflammatory strategies. There have been several interesting studies of levetiracetam, and it is considered that the SV2A protein can be linked to cognitive regression, but there have just been several pilot studies of that. Of course, monoclonal antibodies are being studied very actively, and there is a number of factors that have an impact of all of these mechanisms, and later, of course, they may become key. We shouldn't forget about the link to depression. We know that there is a mutually impairing impact of depression and cognitive impairments. So thank you for your attention, and I will be happy to entertain the questions, first of all, of Rinat and Professor Leis, and of course of the audience. Thanks again. Thank you, Alla. First of all, let us ask our guest if he has any comments.
Do you hear me? Yes. Yeah? I think you asked me a question about neuroprotectors. Actually, we don't prescribe these drugs mainly because they are not reimbursed, because we have a very specific rule, that is, if we have not a level of evidence high enough, the drugs are not reimbursed. So they are available on the market, but in practice, nobody will prescribe drugs which are not reimbursed. People think that we pay enough taxes, and nobody wants to pay more for health because it should be free, and if it's not reimbursed, we cannot prescribe these drugs.
Okay, thank you. Other questions, comments?
I think it's a very important problem, because in my talk I addressed only the question on the targets for prevention, not really prevention, but the targets. And in your talk you went one step further, because
I just followed you.
Yeah, because you addressed prevention, of course, but more because you are also you were also speaking of disease modifiers. I mean drugs that may modify the time course of the disease, and this is clearly something we should improve in the future. We should improve in two ways. First, by preventing the occurrence of this cognitive impairment after stroke or after silent strokes, and secondly, to in those patients who have cognitive impairment, to reverse the system and to modify the time course of the disease itself, not only by the prevention on risk factors, but also on the other factors you have shown. I know this is a common point you have with Régis Bordet, our pharmacologist, to try. Who was the first author of your paper? Yeah.
Я сказала просто сначала по-русски, потом себя же.
I will first say it in Russian. I will ask Professor Lees about the following. Yes, indeed, with his colleague we published a paper about the disease-modifying therapies, but many questions were raised in this paper, and this was kind of a review, and there was no specific answer identifying a drug that would modify the disease or reversing the disease. We did not answer this question. And maybe you have the answer to this question.
Potential disease-modifying medications, but with REGIS, we didn't find a definite answer. Maybe you can give us a different answer.
I think if I had the answer, I would have the Nobel Prize also, probably, because this is something we want to have. We
will vote for your Nobel Prize.
We have targets. One of the targets could be with statins, maybe because it's the easiest drug to study, and maybe also because it's a drug we give in most patients who have a stroke. Not all, but most patients who have at least an ischemic stroke. This could be a target. We have some signals with statins.
But there were 2 Cochrane reviews without a definite
But we have no
benefit.
definite proof, no definite benefit. You are completely right, yeah. We have just a few signals. But maybe other drugs can, but I have no other ideas on that, no. Maybe also the answer is not a single drug, but an association of drugs. Maybe an association of kind of polypills or something like this, yeah.
Ну, соответственно, пока вопрос.
So far there is no silver bullet, no magic pill that could have an impact on the disease or could reverse the course of dementia. So far there is no answer, neither Professor Lees nor we. Renat, do you have any questions? Dear colleagues, we have 1 or 2 minutes left. We tried to be disciplined and stick to the time limit. Maybe some person from the audience has a question. You're welcome. Have a mic, please. I would like to ask, how long are the changes that occur after the silent strokes? For which period of time can they be identified on an MRI? And are there any requirements to the MRI specifications? Is there a specific kind of MRI that could help to diagnose those conditions?
Yes, I think with a simple MRI, 1.5 Tesla, for instance, we can detect most of the lesions, so-called silent lesions. With 1.5 Tesla MRI, we can detect easily silent infarcts. We can detect white matter changes, even with lower field MRI. We can detect microbleeds, maybe not all, but most of them. Most of our patients have a 1.5 or sometimes a 3 Tesla MRI. 7 is mainly for research. Of course, you see more on 7 Tesla, maybe with higher field MRI, we could see even more. But I think already with 1.5 or 3, it's enough. The other, we can see your questions by 2 different ways. The other way could be, when will the dementia or cognitive impairment occur after the silent infarct? This we have no answer because per definition they are silent, so that we don't know when these lesions occurred. And we can just be transsectional and to say at the time T, this patient has 3 silent infarcts, 5 microbleeds, FASECAS-2 score for white matter changes, for instance, but we cannot know exactly what is the time course. What we know is when we follow not patients but normal subjects over time, it's quite difficult to find changes in the brain. And the most powerful marker of cognitive impairment is the occurrence of atrophy. Even a small change in the level of atrophy, sometimes if you perform 3 Tesla MRI, for instance, scans, you measure the thickening of the cortex, so the cortical thickening, and you will see that there is a huge association with cognition. So maybe we should focus more on the cortex, on atrophy, than on silent infarcts and white matter changes or microbleeds, probably.
Thank you very much. I would like... я по-русски буду.
Oh, I will continue in Russian. Thank you very much. I would like to add that, first of all, in our center, we work together with Alla Vediseva, our expert. We say that in case of apathic depression, atrophy is developing, and this is a predictor of cognitive impairments. And another point I'd like to highlight is that, of course, when we see these cross-sectional changes, we don't know which of these silent lesions acted as a trigger, which one of them was the tipping point after which clinical symptoms developed. And as Professor Leith has said, there have been a lot of research on microscopic bleeds, the microbleeds that are believed to be associated with all the issues that we may have, that is to say, epileptogenesis, cognitive impairments, and so on. We have the next question, sorry. Just one short question, please. Good afternoon. You have been talking a lot about medical and drug treatment of dementia, but you did not talk a lot about its link to depression and psychological factors. Has there been any research making a parallel between dementia and psychotherapy, and how efficient it can be? How do you think?
One of the major issues is to make the diagnosis of dementia in a patient who is depressed, because sometimes the patient looks demented, but actually the patient is depressed, and if you treat depression, after a while you can see that you don't have the criteria for dementia anymore. Many of these patients will become demented in the future. It's probably an association between both. So I think the first priority is to be sure that there is nothing to treat. But this is really a good practice for all demented patients to find something we can treat. Hypothyroidia, for instance, lack of vitamins, and so on, or misdiagnosis. Depression is probably one of the most frequent ones. And after we know that if the patient is really demented, there is a link with depression. Patients with dementia are more likely to be depressed, and patients with depression probably are more likely to be demented in the future also. There is a link between two.
Thank you very much. I would just like to add that in our center we have a brilliant group of psychologists headed by Anna Gubanova, and we do see clear results. There hasn't been a lot of research in the world about the impact of various psychological methods. I mean, evidence-based studies, because for me, psychology is like art. However, based on the work of our psychologists, we identify various kinds of therapy and various techniques that do have an impact, absolutely. Thank you. Dear colleagues, unfortunately, we have run out of time. Let us thank our respected speakers for their amazing presentations and their amazing discussion, and let us wish each other longevity without any cognitive impairments and dementia. Thank you, and come tomorrow to our event, and come on the 1st and 2nd of April, as these issues will be discussed. Thank you.